Okay, so now we're going to talk about de-escalation for therapists. How about that? I already went through my introduction. Those of you who are out in TV land are going to have to figure it out. Okay, so by the end of this session, you should be able to describe how attitude and empathy can consciously and unconsciously affect behavior. Should be able to name 2 predictors of aggressive behavior, and should be able to list at least 3 effective strategies to prevent aggressive behavior. Probably many more than that. And there we go. So when we talk about preventing violence, there are basically 3 things that we can manipulate: the environment, ourselves, and the patient. So a lot of times the environment's a little bit difficult because where did you go? You were talking about in the kitchen when there are a lot of sharps around. Sometimes you can remove those kind of things out of the environment, sometimes you can't. When you're in an ICU room and there are tubes and poles and things everywhere, that can be a really dangerous environment. So sometimes we can't change the environment too much. With the patient, when we're talking about the patient, there's not a whole lot we can do about the patient. The best that we can do is with our behavior, we hope to influence the behavior of the patient. So all of that is to say what we're really going to focus on today is you or me. That's the thing that we can control in a situation to prevent aggression. And so I know that some of you are thinking, why are we talking about empathy when we're supposed to be talking about de-escalation? This guy obviously doesn't know what he's talking about. The reason that we talk about empathy in the context of de-escalation is because I've been teaching this for a few years now, and what I've come to understand is really being empathetic is the foundation for de-escalation. It's really hard to de-escalate if you're not being empathetic, and it makes it so much easier if you are. So that's why we're talking about empathy. And I think that hopefully by the end of this talk you'll realize why it's important. Ken Lampert, who is a philosopher, he sometimes works with Palestinian and Israeli groups trying to find common ground. He says that empathy is what happens when we leave our own bodies, either momentarily or for a longer period of time, and find ourselves in the mind of another. I may have screwed up that quote a little bit. But it's literally putting yourself in the mind of another person. Do you think that's easy to do?
No. It comes more. I think it comes easier to some than others.
Okay, it comes easier to some people than to others. Okay.
What about the ones that don't have the same rule base like the social rule base or cultural rule base that you have? And that makes it a little bit harder.
Oh yeah. What about the patients that have really alienating behavior? How is it, what's it like to try to empathize with those patients? What's it like to empathize with a patient who says, get the hell out of my room? Yeah, it's difficult, but science tells us that we're actually born empathetic beings. It's how we come out of the womb. Have you ever, think about it, if you have a baby that's kind of crying their head off and you bring a calm baby into the room, what does the second baby do? Starts crying. We just kind of absorb things around us, and we can be empathetic. It really is how we're made. The reason that we're talking about empathy in terms of de-escalation is because there's research that shows that it increases patient satisfaction. It increases adherence to medical recommendations, which is something that all of us want as caregivers. It improves patient outcomes. Why do you think it improves patient outcomes? Because it increases adherence to medical recommendations. Because they're doing what we're suggesting. So they tend to have better outcomes. It increases professional satisfaction. And I don't know about you, but I'll buy into anything that makes me happier at work. And then lastly, really, and most importantly why we're talking about it today, is that it decreases the potential for aggressive behavior. It's very difficult for somebody to be aggressive and hostile with you if you're saying, yeah, I can see why you feel that way. Put yourself in their position. It's really hard. I've tried it. So just a little bit more about empathy. So empathy is the ability to understand somebody else's position, to communicate that understanding, and to act on it. It's actually all three parts. You have to actually verbalize your understanding to the other person and act on it. So we were talking a little bit about barriers to empathy. You had mentioned one, and here are some other ones. People might just not know about empathy. There could be a lack of knowledge. We talked about that alienating behavior of the patient, which happens every once in a while. Caregivers could be uninterested in being empathetic. They could say, I'm here to do a job. I'm here to do a task. This is not what I signed up for. I didn't sign up to be a therapist. I'm not all touchy-feely. Some people say, you know, I've got too heavy of a workload. I don't have time to be empathetic. That takes time. And I have too many patients to see. I've got too much stuff to do. I would like to challenge that because I think that building empathy with somebody and creating a relationship doesn't take any more time than the time that we're already spending with people. I tell nurses that when you're doing a dressing change, what are you talking about? You know, are you talking about, did you see the football game last week? Did you see the Republican debates? Couldn't believe what so-and-so said. Are you talking about things? Are you creating a relationship with that patient? Or are you just talking about hospital-related things? Because I think that the way to build rapport, the way to build empathy with somebody is by talking about non-hospital related things. That we can do that throughout the course of our day when we're doing the things that we already have to do anyway. There are studies that show that empathy increases with familiarity and similarity. How similar are you to the patients you care for? It depends. Sometimes just outwardly, it looks like we're very different from our patients, right? We have a large homeless population. We've got patients who have addiction issues. Patients could be from different cultures or have a different race than we do. So oftentimes people can look very different. They can seem like they're not very similar to us. But the way that you increase that similarity and that familiarity is by having those discussions that I'm talking about. Whenever I'm having trouble breaking through with a patient and trying to get some rapport with the patient, I'm usually pulling out my iPhone and showing them pictures of my cat. Because it causes that same reaction in them. They're like, oh, he's a crazy cat man. Or they think, oh, you know, I really want to get home to my cat, or I hate cats, or whatever it is. And then you start a conversation about cats, or whatever. And then I really am the crazy cat man. So all of that is just to say that I don't think that having these conversations and creating this rapport and building and creating this empathy for our patients takes any longer. And I hope we'll be happier. And then the last thing is compassion fatigue. If you're burnt out, it's really hard to be empathic. If you're burnt out, if you're stressed, those are real empathy killers. And the only thing that you can do is take care of yourself. I wish there was a magic pill for that, but there's not. So a little bit about assaultive behavior. Assaultive behavior, probably more than 9 times out of 10, always has a trigger. It has a trigger, it has some sort of precipitant. It's just that, you know, in that 10% of the time where we think there's no precipitant, it's just that we haven't noticed it. Or it's something going on in the person's head that they haven't verbalized. But usually there's something that causes the aggressive behavior. There are probably 2 exceptions to that, 2 diagnoses that I'm thinking of. What do you think I'm thinking of? Where there really might not be a trigger or a precipitant that we have time to act on. TBI. Sometimes those patients, if they've got a lot of frontal lobe damage, they don't have any kind of governor, and so they just act on impulse really quickly, and it'd be hard to really find that trigger. And then the other one is sometimes patients with dementia, who also might have some frontal lobe damage. Those patients can be really impulsive, unpredictably so. So let's see. Triggers to assaultive behavior. You did mention paranoia. It can be psychotic symptoms. People with mental illness, as you probably have heard, are no more dangerous than the general population. However, there is a small caveat to that, and that is that patients who have paranoid delusions or who have persecutory delusions, they think that everyone's after them. Those patients can be more violent. Limit setting or saying no can be a trigger for violence. There was a study that was done at Harborview not that long ago where they looked at precipitants to violence on the psychiatric ICU. And what they found out was that the vast majority of the time it was because the nurse or caregiver had said no to the patient or was trying to set a limit. So that can be something that can lead to aggression. And one of the things we'll talk about a little bit later is how to say no without it sounding like a no. So increasing consciousness, infection, pain, bathroom needs is a typical time for people to get frustrated, embarrassed, and can become aggressive. Most injuries that caregivers experience are minor, but over time they add up, and we're not immune to PTSD. Keep in mind, and you guys probably know this, because you guys are touching the patients all the time. The most dangerous time with a patient who is escalating is when you're touching them. That's why when I used to lead Code Grays, when I would show up, I would move heaven and earth not to have to touch the patient. Because as soon as you touch the patient, the increases of you being assaulted go way up. Patients generally don't hit people completely out of the blue unprovoked if you're not trying to touch them. Okay. So we're talking about preventing violence here, and this is really the key point. The key point is that you need to be able to recognize the signs of increasing agitation and do something about it. And really the first sign of increasing agitation is anxiety. So what does anxiety look like in your patients?
Escalated heart rate.
Increased heart rate, sure. What else?
I was say breathing, like when you start seeing them.
Increased respirations. Anything else?
Sort of restlessness.
Restless, pacing, pressured speech, sometimes diaphoresis, sometimes, I don't know, fidgeting. All of those things can be signs of anxiety. So when you see somebody who's anxious, you really have two choices. You can either do something or not do something. When you don't do something, there's a chance that that's going to escalate into an out-of-control patient. If you intervene early, sometimes you can take care of the situation by just asking, hey, it seems like you're upset. Did you need something? You seem sad. Can I get something for you? You seem anxious. Is there anything that's worked for you in the past when you felt this way? Any of those things are all things that can alleviate anxiety. What are some more ideas about alleviating anxiety? What are things that you can do? Yes?
I usually do like have them just take a couple deep breaths, and usually that resets them.
And you do the deep breaths with them, right?
With them.
Yeah, that's really effective. And not only does that help decrease their anxiety, it also teaches them a skill, which is really what we're all about. We're all about teaching skills. So going and getting a warm blanket for somebody, offering them something to drink, some water, some Sprite, whatever it is. All of those things are nurturing things that you can do to alleviate somebody's anxiety. The times where we have patients who are out of control, the vast majority of time people have missed those signs of anxiety, or they've gotten kind of tired of it, and they've allowed the situation, or the situation has escalated. So really, if you can catch this early on, you'll never have to use the de-escalation tools that I'm talking about next. Okay, so Now we're going to get to the nitty-gritty of de-escalation. I've got 7/8 tools for you. The first one is we're going to talk about the environment. What can you do with the environment to make it safer? We already talked about the kitchen with the sharps and all that thing. Sometimes you can remove those items while you're de-escalating. I have a really good trick that when I go for, when I used to go for a code gray, if I was de-escalating you, as I'm talking to you, I'd be saying, yeah, I can see, yeah, that sounds really hard. Yeah, it seems like we could probably do better next time. Oh, excuse me. And I start taking things away to try to make the environment safer when I'm doing it. And that sounds like kind of what you were doing with when you're talking about removing sharps in the kitchen. So you can do that. You want to be aware of the physical surroundings and also be aware of the audience, because if you've got a patient that's escalating, what is an audience going to do? No, it doesn't make it worse. It can make it worse. It can upset the audience. So one of the first things that we do when somebody begins to escalate is I will assign somebody, hey, can you and you, everybody somewhere else, and then we get the audience away. And sometimes that's enough just to de-escalate somebody. You probably already know this, but if somebody is escalating, you want to make sure that you are positioned in the room in a safe way. Right. That you are between the patient and the door. That, I think, were you talking about, who was talking about choking earlier? That you are not up against a wall and pinned into a corner. You want to make sure that you're in a place where you can get out. And, you know, as I'm clearing the room and I'm talking to my de-escalating patient, I'm getting myself in the place where I'm in between the patient and the door. And then be aware of lines, fall risks, things like that. Yes?
So a lot of times when these happen, I think Anna actually had an experience of a while back with a severely head injured patient who refused to get back. He was at the edge of the bed, refused to get back. It was escalating. He took his helmet off at some point. Like he had a hemicraniectomy, and
I think I know this patient.
Yeah. And it was a very big patient safety. We could not leave him. I guess we could.
You couldn't what?
We couldn't leave. Like we had to both be there holding him because he was an incredible high fall risk, and if he had fallen, he could die. I mean, it was so in those situations.
So I think that are you able to hold him safely without being harmed?
Neither one of us really got hurt, but he had the potential. He's a big guy.
Okay.
So,
yeah, not excited about having anybody touching him, but
Yes.
he needed hands-on help to stay sitting and not fall.
So I should probably preface all this by saying this works about 80% of the time.
Most of the time, yeah.
And you're sometimes going to have to use multiple tools. So if one doesn't work and then you reach in your pocket and you pull out the next one, and the next one could be, oops, the verbal skills that you're going to use, and that's probably what I would focus on with this patient, the patient that's got a head injury. That's probably where I would go next. And tell me if any of this is going to help. So I think as one of you already mentioned that if the patient is yelling, you use a lower volume. Try to get the patient to come down to your volume. Collaborate as much as possible. Say, what can we do to make this better? Always try to work with the patient. Avoid saying these 3 phrases. If you can, just get them out of your vocabulary, especially during de-escalation. You need to, no, and why. Those can be really triggers when you're trying to de-escalate a patient. When you say, you need to, I've had patients that have said, well, no, you need to take that pill and you need to shut it, and then they go on. Because, and they'll tell me, I don't need to do anything that you say. You're not my father. We've already talked about why no can be dangerous. And asking patients why when they're agitated or escalating can seem challenging to a patient. It can seem like you're questioning them. So I avoid saying those words. Have you ever heard a nurse who has said, because certainly a therapist would never say this, but have you ever heard a nurse say, if you don't stop doing that, you're going to end up in restraints? I see some heads going like this. Yeah. How does that usually end? It's shocking, isn't it? It's a self-fulfilling prophecy. For some patients, especially patients who have something like antisocial personality disorder, they really need to be in the dominant position in the relationship. And if you are threatening them or challenging them, they're like, oh yeah, really? Yeah, and then they just keep trying to top you. So yeah, don't challenge or threaten patients. It usually doesn't end well. As much as possible, when I'm de-escalating, I try to use neutral words and I try to separate the behavior from the person. So if somebody is cursing at me, I'll say, you know, cursing upsets me. It's really hard for me to help someone when they're cursing. See how different that is from, you can't talk to me like that. I've separated the behavior from the person and sort of made it generic. Cursing upsets me. Taking off your helmet scares me. I'm afraid you're going to hurt yourself. Maybe that wasn't too neutral, but you'll see in a minute. And then this is with the head injured patient where I would really focus. I would really focus on being concise, using simple words, using short sentences, and only one concept at a time. And using repetition and saying it over and over and over again if you need to. That's where I'd focus with the head injured patient, with that guy. I probably would have started saying something over and over again. You're scaring me. I'm afraid you're going to hurt yourself. You're scaring me. I'm really afraid you're going to hurt yourself. That's probably... While we're talking about escalating patients, I thought it was good to throw in, if a patient continues to escalate and you can leave, that may be a good thing. Sometimes you may just need to leave a situation, and then sometimes that can help somebody calm down. Let's talk a little bit about nonverbal communication. So when patients are agitated, there are some studies that show that patients only hear about 7% of your words. The other 93% of the message that's coming through is all through your body language. So when you've got those patients who are cognitively impaired, like your TBI patient or your demented patient, you really want to make sure that your nonverbals are communicating what you want them to communicate. So having a relaxed posture, calm facial expression, making sure that your intonation is also calm or calming, is really important. And you want to make sure that your body language is congruent with what you're saying. Because if you've got your arms crossed and you're looking at your Apple Watch, oh, I got a message. And I'm saying, yeah, I'm really concerned about you. Doesn't really seem like my message is the same as my nonverbals. So, all right. Identifying wants and needs. This is often done in that anxiety phase that we were talking about. Just finding out what the person needs. And sometimes we can meet their needs. Sometimes we can't, but sometimes we can. And sometimes we can use what the patient wants to get what we want done. And I think that we have some similarity here, me being the psych nurse and you guys being therapists, because there are lots of things you want your patients to do, right? There were some things that I needed my patients to do every night at 9 o'clock in the evening. What do you think that was? Take their medication, which was prescribed against their will because they were in the hospital involuntarily. What do you think all my patients wanted? To what? Well, to not take meds, but even bigger than that, they wanted to not be in the hospital because they were all there involuntarily. And so when I was trying to get them to take meds against their will, I would use what they wanted to get what I wanted done. So I would frequently say things like, I think if you take your meds the way that they're prescribed, that you'll probably have a better chance of getting out sooner. I wouldn't make any promises that I couldn't keep, but I would just say, odds are you're going to get out sooner. The judges, it's going to look good to the judge, it's going to look good to your doctors, it's going to look good to me, and I'll be able to chart that. And, you know, it tended to work in my favor 75% of the time. The other 25% of the time didn't go as well. And I think that you guys can use that same sort of thing, because what do your patients want? They want to get out of the hospital, they want to go home, they want to get back to whatever their baseline functioning was, all of those things. And so I think that you can use that to your advantage when you're trying to convince them to do something. Is it going to work all the time? No. Sometimes it will, though. I would say that listening is probably the most important part of de-escalation. I can't tell you how many times I've shown up to a situation where a patient has been out of control, and I've stood in the room closest to the door, and I've just stood there and said, yeah, sounds like we could have done better. I can see why you'd say that. That must be really hard. Yeah. And I just do that over and over again for 20 minutes. And I leave, and the patient's shaking my hand saying, thank you so much, you've done so much for me, thank you. And I leave going, I didn't do anything. All I did was stand there and nod. Just listening is so important to our patients, because so many of our patients are disenfranchised. So many of them have no power. So many of your patients have had so much of their power taken away. So sometimes listening, and by the way, you don't have to do it for 20 minutes like I did, because you're all thinking, I don't have 20 minutes. Yeah, you're right, you don't have 20 minutes, but sometimes just listening for 2 minutes or 90 seconds can make the difference. Just uninterrupted being present and listening to somebody, sometimes it's all you need to do to de-escalate somebody. Listen way more than you talk. Don't take things personally, and try to look at the meaning behind what they're saying, because sometimes you have to hunt a little bit for it. Okay, let's see if this works.
It's just, there's all this pressure, you know? And sometimes it feels like it's right up on me, and I can just feel it, like literally feel it in my head, and it's relentless, and I don't know if it's going to stop. I mean, that's the thing that scares me the most, is that I don't know if it's ever going to stop.
Do you have a nail in your head?
It is not about the nail.
Are you sure? Because, I mean, I'll bet if we got that out of there.
Stop trying to fix it.
No, I'm not trying to fix it. I'm just pointing out that maybe the nail is causing...
You always do this. You always try to fix things when what I really need is for you to just listen.
See, I don't think that is what you need. I think what you need is to get the nail
See, you're
out.
not even listening.
Okay, fine. Listen, fine.
It's just, sometimes it's like, there's this achy, I don't know what it is. And I'm not sleeping very well at all. And all my sweaters are snagged. I mean, all of them.
That sounds really hard. On. If you would just...
Don't.
Okay, sorry for the low volume. You really did have to listen to that, but I think that you got the point. I am such a fixer that the first time I watched this video, I didn't even get it. I kept on thinking, why doesn't she take the nail out? And I think that all of us are like that. I mean, we get into healthcare because we're fixers, right? We want to fix things. So I just thought this was a good reminder that sometimes we can't fix things, and sometimes listening is all that is needed. We're going to have to go through this part really quickly. Next to listening, I would say agreeing with the patient is the other strategy that is probably most helpful for de-escalation. If you ever see me de-escalate a patient, I'm spending the majority of the time saying nothing and listening, and when I am speaking, I'm agreeing with the patient. Now, does that mean that we have to agree with things that we don't think are true? Absolutely not. But you agree with the experience of the patient. There's a communication term called fogging, which means I think it's from when, you know, like in cartoons where there would be a car chase and the car in front would release fog and the car in back gets lost and wanders off. Well, this is like the communication equivalent of that. You fog your patients. And you can fog by agreeing with the truth of the statement. So if somebody says, you know, this hospital sucks, I've been here for 3 weeks and you haven't done anything for me. Well, you can agree with the truth of that statement, which is 3 weeks is a really long time. Or if somebody says, you know, that doctor's an asshole. He just called me a drug addict. How do you agree with that statement? You don't say the doctor is an asshole. And you don't say, well, you are a drug addict. Those two things are off the table. Demetrius. But what you can do is, remember when I talked about looking for the meaning beneath the words? It's about respect. And so all you have to say is, you know, everybody deserves to be respected. So agreeing with the principle of what they're saying. And then if anybody says anything that starts off with, well, you'd be pissed off too if you waited 3 weeks in the hospital or somebody called you a drug addict, you just agree with the odds, which is, well, a lot of people would feel that way. That's all you have to do. Now, if somebody's delusional, do you agree with their delusion? I've had patients who believe that we're pumping poison in through the air vents. Do I say, oh yeah, we shouldn't do that? No, you agree with the experience of the person saying that must be really frightening. And then if the person challenges you and say, well, you just don't believe me, then I usually just say, you know, that's not my reality. I believe that that's your reality, but that's not what my reality is. And I've never had a patient who has challenged that. The only time I will agree with patients who are delusional is if they have something like a severe TBI or dementia where they're not reorientable. There's no sense in reorienting them because it just can further escalate them. All right, setting limits. We're going to do this quickly. Setting limits. There's a 3-step method that I recommend that sounds like it's a little tricky, but once you do it a few times, it really gets to be second nature. So if somebody is doing something and you want them to stop it, 3 steps. The first step is that you name the behavior and say why it's dangerous, scary, fearful, disruptive, whatever it is. So that's when I said, when I was talking about the helmet, taking off your helmet scares me. I'm afraid you're going to hurt yourself. So I've said what it was and why. The second thing is offer alternatives. If you can put your helmet back on, I can help you do X. We can go Y, whatever it is. You offer an alternative, and then if the person makes the right decision, the positive decision, then you thank them to reinforce it. Ah, thanks, I'm so glad you put your helmet back on. That was scaring me. Let's go get a coffee, or whatever it is. Let's go rollerblading. I don't know. So it's 3 steps. It works, and it works for anything. Cursing upsets me. I can't help somebody when they're cursing at me. If you can use better language, I can help you do whatever. And then when they do that, thanks a lot. Now what can I do for you? 3 steps. Okay. And it teaches a skill. Instead of the old days when therapies and nursing was more authoritative, where we would say, stop doing that, don't do that, do this. This really teaches somebody a skill that they can use outside the hospital. Or at least that's the goal. Then quickly, the last part of the de-escalation strategies is the debriefing. And the reason I bring up the debriefing is because if there's ever a situation where a patient does get out of control, it's really important to debrief so that you can figure out what happened. And hopefully try to figure out how to help that, how to keep that from happening again. Look at what staff did, what staff could do differently. Look at what the patient did. I talk to the patient after they've calmed down and say, hey, that was really scary. If that happens again, is there anything I could do differently? Is there anything you could do differently? When this has happened before, is there anything that you've tried that's been successful for you? This is really where you can start to create care plans for people. Hey, I noticed that every time this patient talks to their mom, they flip out. So then you come up with a plan. Okay, what can we do to try to prevent that? How about if when you talk to your mom, you come and get me and I help you and we do some deep breathing exercises together, or whatever it is. But you can come up with a plan. All right. How much time do we have? 14 minutes. Ooh, this is going to be quick. I think that what we're going to end up doing is we'll go through scenarios, and then I will show the personal protection skills. There's really we don't have room for people to practice it. You're going to have to practice it on your time off with your spouses and your children. Okay? But I at least want to be able to show it to you. So let's go through a couple scenarios really quickly. Okay, patient was on an acute floor with a history of mental illness and 2 failed suicide attempts. He had a prior TBI with moderate cognitive impairments and was admitted with injuries to both legs, resulting in him being non-weight bearing on both legs. After practicing some wheelchair skills, psychiatry came to see him, so I left the patient and his mother with them. About 15 minutes later, the med student that was with the psychiatrist came to get me, asking if I would help the patient back to bed. By the way, I took these word for word from what you sent me. I hope that's okay. Is that okay? Yeah. If it's not, it's too late.
No, it's too late.
What did you say? It's too late?
It's too late. You're on camera.
All right. It says, I arrived with the patient and his mother yelling at each other with the psychiatrist trying to clear the room of other family members. The patient was trying to basically throw himself back into the bed without locking the brakes, removing the armrest, or paying attention to his weight-bearing precautions. And his mother was screaming in his face all the while. That's not complicated at all. So what's your priority in this situation?
Patient
What's the
safety.
first thing you're going to do?
Get the mother on
You guys are all over the place.
Lock the brakes of the wheelchair. You gotta get the patient safe.
Okay, lock the brakes of the wheelchair.
Make sure everybody's safe, staff, family.
Okay. What were you going to say?
Get the mother out of the room? Because I feel like you could then do some of those other things. With them being
How can you do that while you're putting the brakes on the bed?
Go towards the bed and do kind of your thing where you're like, hey, could you go elsewhere? Step out for a second.
I can tell you guys are going to steal that. Yeah, I mean, you can enlist help to be able to say, hey, can you get the mom out of here? Because the psychiatrist is in there, right?
Right.
So you can start directing. You can take over at this point because the psychiatrist is probably not going to take the lead in this situation. It's probably going to be, I'm sorry, that's just the way it is. They're probably going to rely on nursing and therapy to help de-escalate this situation. So what else can you do?
Usually just similar situations, just sort of, if there's something I can do to help, like just kind of break up and turn the attention to myself as sort of like, can I, especially if it's a mobility issue, then usually I'm like, oh yeah, I can help with that. At least with the mother, that usually will get the mother calmer. I don't know.
Okay. I think kind of the linchpin in this scenario is the mom. Because I think the mom is escalating the patient, and it's like a domino effect, and everything's coming from, I think that things are kind of coming from that. So from my perspective, my priority goes to getting the mom out. Getting the mom out, and then starting some verbal de-escalation with the patient. So we've got somebody with a moderate TBI who's attempting to do something unsafe. What can you say to them?
I'm here to help you.
That's great. What else?
You can say, I can see you're trying to get back into bed. Let's do this together.
Okay.
You know?
Why are you trying to get him back to bed? Why are you trying to do it together?
And for safety.
How do you feel?
Scary.
I think, for me, when I try to de-escalate somebody, I think it's really important to share how I'm feeling. And so I will let the patient know you're scaring me. I'm afraid that you're going to hurt yourself. And
I want to be calm before we try to continue to transfer
And you want to stay calm. What else can you say to him? He's trying to move.
I say things like, oh, bear with me for a second while I get things set up.
Can you make that shorter?
Just
Just think about that.
give me a second.
Can you give me a second while I get things set up? It's two different thoughts. And remember, what you're going to try to do is you're going to try to use simple sentences, one concept at a time. So what did I hear somebody say over here? Stop. Maybe stop while putting your hand on his shoulder. Stop. You're scaring me. I'm afraid you're going to hurt yourself.
So I have a question about that, because I've had a situation where I did say stop and that escalated things.
Good.
And he said, don't talk to me that way, and it was a safety issue.
What if it was like, just let me help you? And then they have to.
Let me help you is fine. You can't really predict how stop, I can't predict how stop is going to work. Sometimes stop's going to work, sometimes it's not. It kind of depends on how emergent the situation is. The more emergent the situation is, the more I'm likely to say something like stop, followed up by, I'm afraid, I'm scared you're going to hurt yourself. Does that make sense? If it's not that urgent, I might be like, probably can skip the stop. Any lessons learned from this? You want to say something?
No, I just that sometimes physicians aren't the best supervisors.
Physicians, strangely enough, don't get a lot of training in de-escalation.
Right.
It's not really their wheelhouse. They're all about diagnosing and treating.
Yeah.
Not as much into de-escalation, which is why they're probably going to look to you. I think the lessons learned in this have to do with the mom. We've already seen that there's a chaotic relationship there, maybe even a violent relationship. So I think this is where you get with the nurse, you get with the team, you get with the nurse manager, whoever, and you get together and say, okay, this didn't go so well. What can we do next time to make this better? Because, this is clearly a dangerous situation, right? So that's why you have to get together and have those debriefs to look for patterns and try to figure out how to keep something like this from happening again.
Question. What
Yeah.
kind of phrases do you use to get someone out of the room, like the mother? If it's someone that like constantly wants to continue engaging. But...
Me? I would say, I need you to come with me now. And as she starts talking, I would repeat, I need you to come with me now. Come with me now. Come with me. Follow me. Out the door. We'll talk about that later. Come with me. That's what I would do. Short, simple, one concept. Come with me.
Things that, like, I need you to do that, though. Don't you think that could be interpreted as well as you're telling me?
Did I say that?
To do? Yeah, like, I need you to come with me
You're
now.
saying it to her,
Like that.
though.
Okay, I screwed up.
She might have some issues.
De-escalation can be family as much as
Yeah,
patient,
exactly.
You're right. I probably should have said I need you. Yeah, because she doesn't need to do anything I do. Say, come with me now.
I think that situation makes it easier with the psychiatrist on there, because I would probably come in and say, okay, why doesn't everybody step out and I'll help you get back to bed, or something like that, so that it's not just her being excused. It's like
Oh, that'd be great. And
everyone
then you can enlist the psychiatrist.
Yeah.
Can you help her? Can you go answer any questions? Talk to her. Yeah. Thanks for pointing out my error. All right, let's do some personal protection. I have exactly 6 minutes to show you some personal protection skills. Demetrius, since you have been so oppositional, you mind helping?
No, I don't.
All right. So we're going to talk about just some basic things. So the first thing is strikes. So our reaction to strikes is very instinctual. If you go to strike me in the head, my reaction is to block and move, right? So we don't.
It's an inside joke. No.
So my reaction is to block and move, and it's the same for any kind of a strike. If somebody throws a urinal at you, you're going to block and move. If somebody goes to kick you, well, you're going to go ooh and then block and move. If somebody goes to kick you, you're going to block and move. So we're not going to spend any time on strikes. That's generally what we do instinctually. What was that?
Grabbing, they're digging their fingers.
Okay, we're going to do grabs right now. All right. So, Demetrios, if you grab my arm, just one hand, please. I don't know you that well yet. All right, so one-handed grab. So to get out of a one-handed grab, there are two ways to do it. There's one that's really simple, and that's where I just do this. And I can get out of one-handed grab that way. The second way is I'm going to use leverage and momentum and an element of surprise to get out of this. The element of surprise is that, what's he going to expect me to do when he grabs my arm? He's going to expect me to try to pull away. And so I'm going to be pulling him across the room. So what I'm going to do is I'm going to step into him, and I'm going to move my elbow closer to his elbow, and look what happens to his grip. It's almost gone.
This is slow-mo right now.
So it's going to change the angle of his grip, and then I can use momentum to get out. That's a simple way. There are two simple ways to get out of the grip. So once again, it's step in, change the angle of the grip, and pull out. If he grabs me with both hands, it's the same thing. I'm still going to step into him. I'm going to change the angle of grip. So now really, instead of a two-handed grip, it's a one-handed grip. And I can still use momentum to get out. Even if you really try to hold on to me. Are you really trying to hold on to me? Even if he really tries to hold on to me, I'm still going to use that element of surprise, and then I can use my entire body weight against his little hands to try to, he's going to try to, now he's really done it. But if I use my whole body to get out of this, he can't hold on to me, right? So that's why you take your other hand, put it on your fist, use your whole body to get out. So that's how you get out of the death grip. So you do it quickly. And the other thing is that all grabs start as a strike. So if you can block and move, then you don't ever have to do the grab. It's always the little demented ladies. The other thing with little demented ladies is if they grab me, a lot of times if they're demented, they're just wanting me to stay. You know, they don't want you to go, and so I'll say, it's okay, Demetrios, I'm not going anywhere, it's all right. And sometimes that can help to kind of calm them down. But you really do have to kind of take into account who's the patient that we're talking about. Is this a 23-year-old strong guy who's got a history of violence, or is this little old lady? Okay, let's do chokes, because you had mentioned somebody choking. So, Demetrios, I just want you to put your hands on my shoulder. So if he comes to choke me, the first thing is, it starts as a strike. So block and move. If I can't do that because I'm busy talking to Tim about this, now he's choking me. So did anybody remember the old way that we used to teach this, where we used to come up in the middle?
Yeah.
Okay, that doesn't work. Like, try to hold on while I do this. People are very strong across here, so it's really hard to do that. So we don't teach that anymore. So now what we do is we teach you to just go straight up like jumping jacks, and then turn and get out. It might bruise your neck just a little bit, but you'll still be able to breathe and you'll be able to get out. It also works if I'm not paying attention. Uh-oh, somebody came up behind me and is choking me. Same thing, straight up, turn and get out. So what does that do to your grip when I go up like that? It like crushes his hands. So try that with your kids, with your spouses. I'm trying to think if there's anything else personal protection wise. Those are really kind of the, did you say biting. Most of the bites that we have, that I've experienced or seen, are usually more like strikes. They come and they bite and then they let go. Not too much you can do about that other than just situational awareness, making sure that, and most of the time when I see bites in psychiatry, it's because somebody is restraining someone, they're holding an arm like this, they're not paying attention, and somebody leans over and bites them. So you have to have some situational awareness for that. If somebody were to bite and to hold on, just use your hand like that. That's very good, that's your mouth. Okay, so if he's biting me, we still teach that you feed the bite, which is you lean into the bite, which causes most people to open up. If somebody doesn't open up, you can take your knuckle here and you can go really hard here. There's a nerve that goes down here that causes most people to go like that. So those are the things that we teach for bites.
And you guys, I know there's a bunch of questions. We've got a horde of folks outside who have their room at 2 o'clock, so I held them off.